start by talking of how to build an RDN program. And the idea is to try to cover and understand and have some practical steps on building the RDN program. The rationale and the objective of the project is very clear. We do have a gap on the treatment of hypertension. We do have a major failure of controlling and reaching the target of hypertension. After all these years of treating hypertension and recognizing it as a major cardiovascular risk factors, we're still very lousy on achieving the target. So we are not improving the outcome that much by not reaching the target. So we know that we need to improve our CV outcome. We need to monitor the medication adherence, and we need to look at how could we reach that long-term blood pressure control, because all your medications is only for 24 hours and then it disappears, and if they're not taking medication, the blood pressure starts to swing up again. Well, we need to establish what I call evidence-based hypertension interventional program, because we as an interventionist, we need to do what we can do to reduce cardiovascular risk. So resistant hypertension is the major established indication for treatment by renal denervation. And resistant hypertension defined in the majority agree that it's a blood pressure more systolic, more than 140 or equal 140 millimeters of mercury, on three hypertensive medication, including diuretics. Patient intolerance to medication is another area where we need to look at these people and do not just accept that patient will live in misery because he's taking antihypertensive medications. The commonest we see in men is beta blockers and having problem with their sexual life. Of course, you need to have people till now the renal function and the GFR of 30, and others in our GIS consensus we approve the 40 as the bulk of evidence is actually for the 40 ml of GFR. We need to confirm the blood pressure by the 24 hours ambulatory, home ambulatory blood pressure, and the office measurements. And of course, if you don't have the 24 hours, you could use the 7 days home reading once you set up the protocol and educate the patient. Exclude all the secondary hypertension from hypertensionism, renal artery stenosis, that's a must. You need to create, once you are into that program and you really want to start, you need to build up your team. And building the team is very important, and you need to understand the corners of each part of this team, because you need to be either interventional cardiologist or a radiologist, interventional vascular radiologist who can lead the program. You need a hypertension specialist, cardiologist or nephrologist, could be an internist, a nursing staff, and this is very important. Nursing is the core of our business. We will never do anything good without nursing support. So you always need a solid nurse who knows what she's doing and educated to can plan the program. Sedation is important in patients, in particular for the maybe the radiofrequency ablation. Anesthesia is important that they become aware, and you don't want patient to have pain. Program coordinator for the case intake, scheduling, follow-up, pharmacist for the medication reconciliation and optimization, and of course, as we always say, and I said it yesterday and I'll say it every day, a man without data is a man with an opinion. So you need always to keep and follow and register your numbers and your data so you can present and you can tell people and you can even convince your administration about what you're doing, because they need to see numbers. What is the required? Of course, you need the cath lab. You need to have an access to an ultrasound. A lot of people, because we still do it femoral, a lot of the people, I have seen it. I was trained in a femoral era. So our skills in the femoral is totally different from the new generation. I've seen when it comes to the femoral puncture. I've seen that they need an ultrasound, and I said, okay, do what you're comfortable with, because we don't want problems. They are more skillful in radial nowadays, and they train on radial more than train in femoral. We were trained in femoral and then radial, so we're different breed. We need a CTA or an MRA before the procedures for renal artery assessment, looking for accessory renal arteries, because that one you could miss, and 25% of patients, they have an accessory renal, more than one accessory renal artery, which is very interesting. The devices you need at the clinic, which is your blood pressure monitoring for at home. If not, you can handle it with a proper home reading for 7 days. You need to have the FDA-approved systems. There are 2 systems approved by the FDA. You need to be familiar with both. You need to train the operator and be competent in using either the RECOR system, the ultrasound denervation system, or the radiofrequency Medtronic Simplicity Spiral. And I believe both are important. You need to have the comprehensive hypertension evaluation, including the medication optimization, baseline function, renal function, electrolyte, renal imaging, the 24 hours, patient education, and that's very important, and the formation of the team. The procedures, it depends of the kind of procedures. If you're using the RF, then you need some sedation, femoral site preparation, and the use of ultrasound, maintaining the ACT, the selective renal angiography. Use a vasodilator, please, because you really need to size the vessel properly. Do the ablation and try to as much comprehensive ablation as possible. Documentation of your ablation points and angiographic outcome is very important, because you really need to know if they fail, why they failed, and you need really to have a proper documentation. Don't go in and say, well, denervation is done, full stop. And I've seen that, and you don't know what they have done. So you need really a proper documentation, how many points of denervation you've done, and which system and all that. Post-procedure monitoring for bleeding, renal function, and vitals. Post-procedures, 2 to 6 hours observation. I keep them overnight. Renal function assessment, 72 hours. Discharge with a blood pressure monitoring table. And avoid, tell the patient you're not allowed to do exercise for 72 hours. You see them in 1 week with safety lab, symptoms check, 1 month office blood pressure and medication assessment and readjustment, 3-month treatment readjustment, and of course, you do the ambulatory blood pressure at 3 months to document the difference and the response. 6 and 12 months, you do the follow-up imaging if required, or long-term blood pressure assessment, and then you have the annual follow-up for these patients. Establish a referral program always. It's very important to look around you and understand and do like a helicopter view of your hospital and where are the referral that you can actually get patient from, and what are the eligibility checklists. Go and talk to people and try to centralize the intake by your program coordinator. Quality assurance and KPIs are important, so you need to have people who are actually monitoring the medication burden changes, the change in the blood pressure, the complication rate, the operator metrics, how many cases, and all the radiation exposure and everything, because that's where you're going to actually show the difference. You monitor all your KPIs. You need to document your procedure and have a standard, so not everybody does what he wants. You need also to have a clear cath lab protocol for renal denervation, and do your assessment, because money talks, and always it's very good when you want to go and convince your administration that you show them that we are saving money, we are reducing complications, we're actually reducing the long-term burden of our hospital when it comes to hypertension patient. I'm going to go back. Creation of private patient packages is very important. And this is, I say, there are patients who are actually willing to do it, but they need a a lower cost package. And that's where you have to go and convince your team. Communication, you have internal communication. So you start with your own hospital, do grand round, send letters, do department meetings, initiate the movement of renal denervation, okay, within your hospital. That's internal communication. Get out to the community, find the societies, find who's actually have some events or a marathon or whatever, and go and try to give a lecture, go to educate people with newsletters, and go and talk to the family medicine who are sitting in the community. So education material as brochures and patient videos are important, where you have a testimony of the patients and how this and how the therapy changed their life. Thank you very much.